different criteria to identify, sort of sort out the seriously injured from the minor or non-injured patients. And the very last piece on this is EMS provider judgment. So although it's been used in many systems for years, it's only been formally integrated to the algorithm since 2006, so it just made it onto the chart. Previous studies looking at the value or the accuracy, basically whether it's useful in identifying seriously injured patients, have had mixed results. And recent research, that is the last talk that you guys just heard, suggests that EMS provider judgment is actually a major driver for trauma triage. So for this project, we sought to examine the independent predictive value of EMS provider judgment relative to the other triage criteria. So again, trying to account for the presence of other triage criteria. And in many cases, there are people that meet multiple criteria. And we also conducted a qualitative analysis, so basically looking at those chart narratives. You guys work very hard on doing in looking at those to get a little bit more texture on these patients, some field-based contextual information for patients meeting different triage criteria and basically patients that are meeting different steps of the algorithm, whether they're identifiable and unique or whether this whole group sort of blends together. So we conducted a population-based retrospective cohort of both kids and adults, 43 agencies transporting to 55 hospitals, trauma and non-trauma centers. This is 3 sites. Remember I mentioned earlier that we've been collaborating with our colleagues in multiple different locations. This includes Portland and Vancouver data, as well as Denver and Seattle-King County. This is done over a 3-year period. 26 plus triage criteria were looked at. We looked at them in order of the steps that they are outlined in the algorithm, but importantly, we selected out judgment, okay? So since based on the last talk that you heard, we thought that really shouldn't be lumped in with the rest of the special considerations, but really functions independently. We accounted for age, site, hospital type. The primary outcome was serious injury as defined by an injury severity score of 16 or greater. And for those of you who may not have heard this term before, it's basically an anatomic measure for how seriously injured a patient is. We also did, as I mentioned, qualitative analysis looking at all the chart narratives and processing common themes from that. This study included almost 182,000 injured patients, 13 of whom met triage criteria, and 4% of whom had serious injury. Judgment, as noted in the previous study, was cited more than a third of the time and was the sole criterion in a quarter of patients. So this is sort of the money slide here. This is the multivariable logistic regression model results. I'm going to orient you here, but the point of using statistical analyses like this was to be able to try to isolate the effect of EMS provider judgment after accounting for the presence of other triage criteria. So every patient could have had up to 3 criteria listed, and to try to tease out the effect, kind of the net gain that you get from EMS provider judgment, we had to put that into a statistical model that was able to account for a lot of other factors. So on the y-axis here is the odds ratio of serious injury. This is just a measure for the relationship between each of these factors and serious injury. We can see that for the first 3 up here, physiologic, anatomic, mechanism, those all had pretty strong associations, 8.5, 4, 5, with serious injury. Risk factor, much less so, although still in association with identifying seriously injured patients. And importantly, this last one on the right side here, an odds ratio 2.7, essentially means that for after accounting for the presence of other triage criteria, EMS provider judgment had an odds of 2.7 for identifying seriously injured patients compared to patients that did not have that criterion listed. So in short, this quantifies the benefit of your cognitive processing. It validates what you guys are doing in the field as far as individual provider judgment. Qualitative results. So this is looking at basically chart reviews. Physiologic and anatomic criteria patients, they were clearly sick, high acuity, altered mentation, distinct, and pretty straightforward to identify. These were sick trauma patients. often had externally visible injuries, not a lot of question about entering these patients. The murkier ones came with mechanism and risk factor or special considerations. These were less obvious. May have had concerning mechanisms. They may or may not have explicitly fit the actual triage criteria. And those patients that fit EMS provider judgment had concerning clinical presentations, but did not explicitly meet any of the other criteria, at least in a quarter of the patients. Substantial overlap with patients in the mechanism and risk factor categories, and these patients were clearly distinct from non-criteria patients. That is, suggests that they are identifiable when taking into account contextual and situational factors at the scene. All right, at this point I'm going to turn things over to Captain Hollingsworth here to add his comments.
I'm Mike Hollingsworth, the EMS officer for Clark County Fire District 6. And basically I'm just going to echo what both Doug Boyce and Dr. Newgard have been saying, and that is that if you do look at the trauma criteria algorithm, that the EMS provider, and in our county it's the paramedic judgment, is at the bottom of the list. And when I do chart reviews for our department, there is substantial evidence that shows that some of us probably don't know that algorithm, so we go down to the paramedic judgment anyway and make that call and call it that. We may miss some of the anatomical criteria or the physiological criteria, but nonetheless, it's captured. Either that or we have a private meeting with the MPD, and I think some of that drives that, entries into the trauma system as well. So I think we have underestimated the value of the paramedic decision or the BLS provider decision, because it's not always a paramedic if you're working in the BLS system. And it certainly does need to be modified to include that higher up in the decision process. So, again, in reviewing the charts from at least my department, we have noticed that there has been times when we would probably have missed that trauma entry criteria based on, say, falls, for example, would be an idea where it's very clearly laid out if it's less than or greater than 20 feet. Well, if you fall 18 feet, you probably have seen some significant injury as well, and that leaves that avenue open for the paramedics. So there truly is a space or a place for gut feelings. So in conclusion, we do feel that it needs to be seriously addressed, and it sounds like those places are in motion. So if you know me, I can ramble on for hours, so I know we're behind the game. So do we have any questions? Okay, thank you.
All right, folks, so we got one more talk left. I appreciate your patience, and again, I am certain that there are more questions out there than are being verbalized. So after we're done this morning, I hope that you guys will at least start to talk about those questions, whether it's within your agency, with your medical director, with any of us. I think continuing an open dialogue is very important to make sure that your questions are raised. In some cases, they actually drive future research projects. So I'd encourage you to come forth with your ideas and your questions, because this clearly is a collaborative, bi-directional sort of effort here, and things that may seem obvious to you may not be obvious to those who work primarily in a hospital setting. Okay, so the last talk is going to be done by Mark Muir and myself, and is looking at validating the National Trauma Triage Protocol. So clearly we're focusing a lot on triage here. This is something that all of you are integrally involved with. A little bit of background, much of this has already been covered. The original field triage scheme was developed in 1976, periodically modified. If you actually look at the data for where this algorithm came from, it's primarily based on research for individual triage criteria, sort of taken in isolation. Some research is focused on components or steps of the algorithm, And to a large extent, certainly in the early years, it was based largely on expert opinion. So what this essentially says is that there's been very few studies that have looked at the algorithm in its entirety, okay? So we're still not certain how well it works, whether we're getting the right people where they need to go. The sensitivity, that is the number of patients with serious injuries that are identified by the algorithm, has been reported to be 60 to 95%, so sort of a wide range here. Most of these have actually been closer to the 90 to 95% value, but there's been some significant limitations in previous research, whether it's just involving patients in a trauma registry, transported to a single hospital. Most studies have failed to really look at the broader portion of, or broader injury population that you evaluate in the field. Basically those that actually have the triage protocol, some application of that to them. So the true accuracy of triage criteria basically remains unknown. That was the basis for this project. So we sought to describe the use and validate the accuracy of the National Trauma Triage Protocol for identifying seriously injured patients in a large and diverse injury population. Again, this is a population-based retrospective study, so that's important to keep in mind. This was looking back, not forward. There is a study in progress right now that is a prospective study of these guidelines that is the first of its kind in the country that Clark County is partaking in. This project involved 45 different agencies, 31 hospitals, included the 3-county Portland area, as well as Clark County and Seattle-King County over a 3-year period, and patients meeting any triage criteria per EMS. So this was not someone looking back saying, oh, it looked like they qualified for blood pressure. This is what you put into the chart, and those patients that were entered in the trauma system were considered field triage positive. So more of a real-world look of what's happening. We looked at different age strata. Primary outcome, similar to the previous project, was serious injury by an ISS score. However, we also looked at AIS scores. Against these are different anatomic means of determining whether there was a quote-unquote serious injury. The AIS of 3 or more is a little bit more liberal definition, sets the bar a little bit lower for defining serious injury. And we looked at major surgical intervention, specifically non-orthopedic surgical intervention. It's been one of the measures used in a lot of other previous triage studies. So the results, there were just shy of 177,000 injured patients. You see this number on each of these presentations fluctuates a little bit depending on the sites in the study. Just over 12% met at least one triage criteria, and 3% had serious injury. So similar to what we've seen before, the top 5 triage criteria cited, once again, we're seeing EMS provider judgment come up as the most commonly cited criterion, at least in this sample was used 27% of the time. And then the next top were basically in order: GCS, age extremes, high energy mechanism, and finally penetrating injury. So here are the overall results. So this is all comers, all ages, all sites. The overall accuracy for identifying patients with serious injury has sensitivity of 80%, specificity of 91%. So if these numbers don't sound familiar, the flip side of this coin is under triage rate. So essentially the miss rate is the counter side of the sensitivity coin. So it basically meant that we were missing 20% of seriously injured patients in the field. Now, if we look at this with the different outcome measures, so I mentioned before that AIS was a more liberal definition of serious injury, set the bar a little bit lower. So here we see the sensitivity of about 33%, basically meant that the yellow part of this pie chart here, 2/3 of the patients with serious injury as defined by an AIS score were actually missed by the triage criteria. Again, specificity remained high, which is unique and quite different from most of the previous research on this. A lot of people in the past have been worried about over triage rate, maybe less of an issue. And for surgical intervention, so non-orthopedic surgical intervention during their hospital stay, over 1/3 of these patients were not identified by the triage criteria. And finally, when we look by age, we split this out by children, adults, and elders. We see things look pretty consistent between kids and adults, at least up to 64 years. And then elders, interestingly, the under triage or miss rate was twice that of the other age groups. There's been a couple previous studies suggesting this, but no one has looked at it as directly as here. I'm going to, Mark, you want me to go through this slide and then have you? Okay, so some of the summaries before I turn it over to Mark Muir. So the under triage rate in the National Trauma Triage Protocol is higher than has been previously described. Does that mean you're doing a bad job in the field? Absolutely not. Okay, it's a matter of understanding the system and what could be potentially improved upon. There's also a possibility, say for example, these trauma systems are very mature, well-developed trauma systems. This probably represents a best case scenario. So other systems that are not as high functioning, not as inclusive, not as well developed, probably their numbers look quite a bit worse. And the other caveat with this is that this is a look back in time as opposed to forward in time. The look forward in time, prospective studies generally generate much more rigorous results, and that's what we're in the midst of right now. So we will have some follow-up numbers to report about a year from now. The under triage rate for elders is significant. There's been previous literature to suggest that the older population doesn't derive much benefit from trauma center care, so we're still trying to understand what needs to be done with the older injured population and how these numbers may apply for them, how the system may need to be tweaked to improve our care for them. Under triage, as I showed with the different ISS versus AIS pie charts, looks worse with more liberal definitions. So if we set the bar lower for what is considered serious injury, it looks like we're missing more patients. So this, to me at least, suggests that the triage guidelines do a reasonable job, though not perfect, at identifying more severely injured patients and probably miss a more significant number of those in the moderately injured category. Question of who needs to be at trauma centers and would benefit the most from trauma centers is still sort of under active discussion. And specificity, that is the over triage, that is the number of non-injured or non-seriously injured patients that are transported to trauma centers. This is actually much better from these numbers than what's previously been calculated. In the past, there's been a bunch of papers published, especially in the surgical literature, saying that over triage rates are overwhelming the system. We need to be careful about this. While those are certainly concerns and the number of non-injured patients drastically overshadows the numbers with serious injuries, specificity was much better here than has been previously calculated. And it's probably also a matter of working with a population that's much more reflective of reality, not just those taken to a trauma center or not just those captured in a trauma registry. So at this point, I'm going to turn the mic over to Mark Muir.
Thanks, Dr. Newgard. My name is Mark Muir, and I am the assistant to the medical director for Clark County. I work for Dr. Whit. I'm essentially Dr. Whitwer's little boy, I guess, for those of you who are experienced with some of the things that I actually do. Some of the concerning things, I think, from the face of this particular study, from a clinical standpoint. Part of my job is quality assurance, so you can take that to mean that I assure quality. I'm not sure that I really do that. I just review what it is that pre-hospital providers do and hopefully provide you some information to help you either improve, give you positive feedback so you stay really good. Essentially, that's kind of what I do. The concerning thing is the under triage was higher than previously described. The data in this study showed that, or the data in this review showed that. Of special note was the elder patients. I think that's very interesting in going forward with this, and the study that Dr. Newgard talked about is one that he is the principal investigator in, and that we will be participating in. And essentially what's going to happen is that we will submit data for them to review to determine cost effectiveness of our trauma system, our ability to triage patients in the field, and tweaks that we need to make either to the system itself from a pre-hospital standpoint, from a destination standpoint, and they're also going to look at the cost effectiveness of all of that put together from a system-wide standpoint. Of interest, I also noted or saw that being able to triage seriously injured patients, we do a pretty good job of that, and I think that's evident in some of the previous research that's been talked about here. It's easier to recognize physiologic and anatomic criteria, I think, and that maybe the paramedic judgment issue that we've talked about previously needs to be looked at. I mean, we are kind of in the midst of a paradigm shift. When I started as a medic in, when was that, Mo? 1990, that was a long time ago.
89, Mark.
Oh, that was 89, that's right. Brad and I started at the same time. That was, as Dr. Dye and I like to kind of jest about, my hair color was a little different and he had more of it when we actually started. So essentially the paradigm shift is that we had a dispatcher for the particular ambulance company that I worked with at the time, and in working in Clark County we had a lot of trauma that would happen here in rural type areas. This dispatcher would dispatch us to trauma calls based on his feeling. He would dispatch an initial unit, and based on the information that he received from his initial triage, he would say to us, "I have a feeling," and he would always send another ambulance or two or sometimes three, irregardless of without concern for the time of day or the number of calls we'd run previously and whether or not we were sleeping. He would sort of shift us towards these particular calls. It worked for him one time. Out of the hundreds of calls that he did this for, he finally eventually was told, stop doing that. I think you take that from a generalized standpoint, from the trauma system that we exist in, what we're doing, the paradigm shift is that we're studying this particular piece of information and designing a system that's most effective for taking care of the patients that we're dealing with. I'll keep this quick because I know we're towards the end. I already spoke to that specifically in Craig's study. Of note, the other thing that I wanted to mention is that these results that we've presented here today don't hold much merit unless the information that you all provide in the field is accurate and complete as possible. And I think you guys do an excellent job of doing that, and I just wanted to encourage you to continue doing that, because we can't design systems without good quality pre-hospital data in the very beginning. So with that, any questions? Thanks for coming, yeah.
Has there been any study, like here at Clark, we do the trauma alert versus the trauma team activation in our care report. Has there been any studies of alerts after care is given over that have gone to team activations, that we have things that we are missing, or because we can bring in a trauma alert and then leave the hospital and don't know that patient will do a full trauma team activation? Is there any studies of that?
Right. What the question is, and in Clark County we have trauma alerts versus trauma teams, and basically essentially what that means is, from an in-hospital standpoint, whether or not certain resources respond to the call within a certain period of time, basically. And whether or not do we look at data to determine whether or not pre-hospital trauma alerts become trauma teams after arrival. That's a great question, and yes, we do look at that. We do. I can give you anecdotes about when that does happen, but I can tell you generally, upgrades are usually made, the majority of the time are made due to patient deterioration upon arrival at the hospital. So from a pre-hospital standpoint, we do a pretty good job. And I can tell you that our data locally shows that the triage issues that we do have are usually age dependent and are pretty consistent with what Craig and his group have found from a regional standpoint. Yeah.
Any idea specifically on why the elderly are being so underdiagnosed or under triage?
So the question was, any idea why there's such a higher under triage rate among the elderly? It's an excellent question, and I think the shorter answer is that it's not totally understood. I think if we look, this is not just an out-of-hospital phenomenon, but there is some likely subconscious differences with the way we treat people based on age. So if an 85-year-old patient comes in with a certain diagnosis, are they treated differently than a 50-year-old patient? Through some kind of subtle ways, I think they often are. And this comes into place for STEMI, stroke, interventional care, all kinds of different situations. So why the triage criteria tend to miss that group, whether this is sort of a cognitive issue where, you know, the criteria may have been there but weren't recognized and therefore the under triage rate looks higher, or whether they just don't, those triage criteria don't work that well in the older population. I mean, certainly physiologically, age is a big factor. So for kids and adults, those groups have all those numbers that we use, systolic less than 90, respiratory rate, et cetera. Those are extrapolated from primarily adult data. So it's not clear whether they should be sort of a different set of criteria for elders. And the 30,000-foot view on this is that some of the biggest studies that have been done for the benefit of trauma care to the injured population, none of them have been able to demonstrate a benefit of trauma center care among the injured elder population. So again, it may be that mortality is not the right outcome to look at. We need to be looking at other measures, complications, infections, morbidity, but the elder population continues to grow in this country, and I think it's a very big topic that's going to get bigger in the future. Other questions? Yeah.
You tend to notice more of a miss on triage in highly populated or closer areas of the city as opposed to rural. You've got such a short transport time.
Yeah. So excellent question. Just to repeat it from the folks that are watching from stations or other locations. This is a question about whether the triage criteria differ based on the location, whether you're in close proximity to a trauma center or out in a rural area. And I'd say it probably does, but it's not entirely clear. The study that Mark has mentioned up here, the CDC triage study, so this is the prospective study that we're in the midst of right now, that is prospectively, that is looking forward, looking to validate what the real accuracy is of the triage criteria. And one very unique part about this is that we have two counties that are primarily rural. So Skamania County in Washington and Josephine County in Oregon are part of that effort. And how triage works in rural settings is, at least as far as the medical literature, a total unknown. It's how air medical services are really utilized when there's not, you know, the nearest trauma center maybe 300 miles away. It's not an option to take someone there. Clearly they're different, but in sort of teasing out the details of how they're different, how it should be done, you know, what functions a rural setting is still a relative unknown. And I do think in more densely populated areas, there's probably a lower threshold for taking someone to a trauma center because the penalties are not huge, the transport times are not that much different, and so therefore the way triage is practiced, I do think differs based on geographic location. Any other questions? Okay, so I want to thank all of you for coming today. I hope that this has been informative. I'd like to encourage you once again to fill out the evals. It takes a couple minutes of your time. Really, this conference is for you, not for us. So we want your feedback and how it could be made better. If there are specific questions you would like to see addressed, either through research projects or just future talks that we hold, whether you thought the benefit of seeing local, that is your own data, was helpful. Any other feedback, we're very, very open to receiving. I want to thank all the people that helped put this research summit on. all of our help from our research staff, as well as all the local agencies, EMS medical directors, Chief Barnes here. Thanks very much for your attention, and I'll be hanging out for a little while afterward if you guys have questions that you'd like to talk about. Oh, we have.
I just wanted to also say something. We talk a lot about data, and I just want to remind you guys that when we talk about EMS data, what we're talking about are your charts, the documentation that you guys provide, and your monitor files. So our research team has looked at, and when I say looked at, I mean manually reviewed and extracted data from coming up on 30,000 charts over the last 5 years. We've done data review of tens of thousands more, and I just have a huge amount of gratitude for the time and effort that goes into that documentation. And I just want to remind you, from the research point of view, that is your opportunity to present the voice of EMS care to really change the science. And so I just have a lot of gratitude for the amazing documentation and the amazing work that goes on in this field here.
All right.
Also, as you turn in your evaluation, you'll get some CEUs. So make sure you've completed your evaluation. If you'll turn them in, then they'll give you a slip to give you credit for CEUs. Thank you.